So someone asked about confrontation visual fields, and the first thing you need to know is the word is confrontation, not confrontational. Confrontational means this. Confrontation means this. So please don't write confrontational. That is about you, not about the field. The confrontation visual field is done with your fingers and with handheld targets. The reason you might have to know how to do this is, number one, you don't have access to an automated perimeter. So when would you not have the Humphrey visual field? Well, that's going to be the emergency room or the bedside in the hospital. You don't have a field machine. So for those patients, you have to do confrontation testing with your fingers. The second is if you have an unreliable Humphrey visual field, or the patient's simply incapable of doing the visual field. Either they don't understand the directions, or their vision is too terrible to be tested. Number of reasons why it would be unreliable. The third is if you're trying to differentiate a tunnel field versus a funnel field, and a tunnel field is non-organic. A funnel field expands appropriately on 1 meter and 2 meter testing, and that is an organic field. So these are the main reasons why I would do a confrontation field on someone. Either I don't have a field, I have an unreliable field, or I'm trying to prove that someone's a tunnel rather than a funnel visual field. So how do we do this? Well, you have to set yourself up to look at the patient, and you're going to present the target. And if you just want to use your fingers, it's fine. But you can also have a red top tube of some kind. Red is better for sensitivity. And so we're going to present the target in the 4 quadrants. How many fingers? 1, 2, 2, 1. We're going to move the target across the vertical meridian because for neuro-ophthalmology, we want to know, is it respecting the vertical step? So they have to close the affected eye, and you can use yourself as a control by closing your eye when you're testing them. And so if we have a field that is respecting the vertical meridian, where you're moving the target across here, like this red top, and they say, oh, I can't see it as well, as soon as it crosses that midline, then the second thing we're trying to do is establish whether it's bitemporal or homonymous. And you can do this with a confrontation visual field. You don't need a machine. So you're not really trying to detect some subtle arcuate defect with confrontation field. You're really just trying to figure out, does the person have a homonymous hemianopsia or a bitemporal hemianopsia, yes or no? You're going to accentuate that by running the target right across the vertical meridian. You're going to be seated across from the patient at the same plane, using yourself as a control, covering one eye, and you're going to really test across that vertical meridian. This is a confrontation visual field. You can do that at the bedside. You can do it as someone who can't do a Humphrey. And we're going to test at 1 meter and 2 meter testing if someone has a constricted field or central scotoma. So in a patient who has a constricted field to, say, a 5 to 10 degree island, if we double the test distance, we should have expansion of that visual field. If, however, it's a tunnel field, it stays 5 degrees at 1 meter and 2 meter, that is a non-organic field. Functional neurologic disorder, we call that now. Same thing with the central scotoma. If they have a central scotoma, if you go backwards, you'll have expansion of the field, but the central scotoma will get bigger and you'll be able to test it better. So the central scotoma and the sparing of the center can both be tested with a confrontation field at 1 meter and 2 meter. And your main job is make sure it's not respecting the vertical meridian, homonymous, or bitemporal hemianopsia.